One of the other things that we saw at GU ASCO, and there's a little bit of some updated information as far as quality of life and biodistribution data that was presented at ASCO this year, is the use of sub-Q PD-1 agents. And I thought maybe we would each go around and just start brainstorming about how we think that this could be practice changing, or if you think it's going to be practice changing. I think many groups are looking at creating a sub-Q injection, and we've seen the data from CheckMate 67, I think, that basically was a non-inferiority trial, looked in patients with metastatic RCC and met its primary endpoint for being non-inferior. And then the updates at this ASCO Congress is basically showing that the quality of life was equal between the sub-Q and the IV formulation. And then they had a nice poster as well, basically looking at distribution and bioavailability based on BMI. And it looks to be pretty similar, recognizing that some of the cohorts were a little bit small. And so it's a little hard to acknowledge that that's true in the extreme BMI categories. But maybe we'll just go down the line and just brainstorm about how at your institution or your practice, you know, if you think that this is going to be impactful to you or to your patients.
Yeah, I think this is a great strategy actually to start utilizing sub-Q as opposed to IV for a simple reason, basically not patients timing, you know, so it will be faster to give the sub-Q versus the IV. And another important factor, which we are running all the time into, is the space for our patients, you know, for infusion suite. So if we are saving the time for both the patients and the infusion chair, I think that will be a huge advantage in practice, you know. So it's reassuring to see the tip of the iceberg, if you will, for the non-inferiority data for the sub-Q compared to the IV. And more importantly, what we are looking forward to see the data from patient-reported outcome, which the abstract suggests that there was no difference between the two modality. So I think if the data holds that way for the large randomized clinical trials, I think that might be a practice changing simply because of the practicality of this approach.
Yeah, I completely agree. And from a methodology standpoint, many methodologists get very opinionated against the idea of looking at changes from baselines in randomized trials, and we do that a lot every time that we look at PROs and quality of life, etc., which gets hardcore methodologists very angry. This particular trial, I was pleasantly surprised that it actually did emphasize comparative inferences at specific time points, which is thumbs up from a methodology standpoint. We don't often see that in the oncology world.
And Ben, what do you think? Do you think you're going to be using it?
I really liked it. Really, just from a practical standpoint, you know, when I think about our cancer center, you know, where we're located in Utah, and we're the only major academic center in multiple states, we have a lot of patients that come to us from many hours away, and not only will this hopefully help reduce the burden on the infusion center, but also for patients. You know, we're also beginning, I would argue, but we're moving into this era of trying to, you know, better do telehealth, et cetera, for patients. And now if you have a treatment that you can pair with, or you know, partner with that sort of strategy, now you can actually deliver the treatment and provide some oversight at the same time without having patients travel, you know, 5, 6, 7 hours one way just to come to your cancer center. So in the Mountain West region, this was really welcome news.
Yeah, I think Ben makes an important point. AACR came out with a publication, sort of a summary of, you know, disparities and outcomes with patients. And one of the big issues is a lot of these newer therapies we're all excited about and we give our patients, they don't filter down to a lot of patients with cancers, that some of which we treat and others that we don't. So if, to his point, if this can extend access to people who have issues around traveling, that's great. We obviously need to do more around cost and duration of therapy so we can build these other ways of making these agents more accessible potentially to patients. And we need to work on that because we get excited about our progress, but if our progress doesn't filter down to every patient, we haven't really made as big of an impact as we could.
Yeah. I wonder, and I think we'll grow and learn as we're doing more telehealth and getting more access to people, but I wonder what you all think if we'll just develop novel supportive networks, because it's, as an injectable, you know, I think my concern is if somebody's having a immune-related adverse event and they're 6 hours from your site, and you've tried to get local labs and things like that, you know, to help monitor, but the patient to have that available, you know, I worry a little bit about the safety for this particular category of medicine. If we'll have to partner with local medical, you know, I don't know how this will like roll out to increase accessibility.
Yeah, you know, I think that's a critical point, but to me that means in the first few doses you should be seeing those patients.
Yeah.
Because that's when, at least in my experience, that's when most of the horrendous outcomes happen in the first few doses. So getting those patients back to actually see the people who are writing for the orders is key. But when you get to month 6 or month 12, there's usually not new stuff happening.
Right.
So it's when you can extend access, I think.
Right. Yeah, maybe putting those safety halts up front, or saying,
right,
we recognize that now you've been on a stable dose and doing well.
Right, absolutely.
Yeah.